I'm going to kick us off here. My name is Dina Rifkin. I'm a professor of medicine here at UCSD and one of the faculty advisors along with Dr. Marty Stein for this first lecture program. For the last 11 years, thanks to the amazing work of our student leaders and with the ongoing financial support of the Dean's Office, we've been able to welcome a physician author to speak to our students and give a broader perspective on the work we do in medicine. I am so thrilled that Dr. Michele Harper is joining us today as the 11th first lecture speaker. From the start, this was a student-driven enterprise, and I'm so proud to have witnessed the work that this year's second-year students have done in their committee to make today's event happen, from contacting Dr. Harper to leading book discussions, and now to introducing our speaker and moderating today's event. So it's my great pleasure to introduce second-year medical students, almost Dr. Katya Lazar and Dominique Patterson, who will introduce our guest and lead the events from here. Thank you, Katya and Dominique.
Thank you, Dr. Rifkin, for the introduction. Dr. Michele Harper was born in New York and raised in Washington, D.C. She graduated from Harvard University and completed medical school at the Renaissance School of Medicine at Stony Brook University. She completed her residency at Lincoln Hospital in the South Bronx and is now a practicing emergency medicine physician with over 10 years of experience. She has gone on to practice in New Jersey and Philadelphia. Dr. Harper published The Beauty in Breaking in 2020, which has gone on to receive generous praise and numerous accolades. The UCSD School of Medicine is privileged to have Dr. Harper presenting our first lecture and to engage in conversation with her today.
These days, resilience has become a kind of buzzword for the ability to return to or maintain our productivity in the face of hardship. But this book redefines resilience as the adherence to our true selves, to accept, process, and give space to feelings rather than void them and deny our humanity. On behalf of the UCSD School of Medicine, I'd like to give a warm welcome to Dr. Michele Harper.
Thank you. Thank you both, and thank you all. And I'm sorry that we're in a global pandemic and we can't do this in person, but we'll make it work and do it safely anyway. And so The Beauty in Breaking, I discuss many topics. So I had many areas to choose from in developing this talk for you all today. And anyone who knows me, anyone who's familiar with my work knows that I am rooted in this paradigm of social justice. So just a nod I want to give right now to intersectionality, because none of us are single issue people, certainly no one who identifies as activist or spiritual or just decent. We work together to confront structural bigotry wherever we see it. And certainly when it happens to anyone, it happens to all of us. It is interconnected. So in service of that mission, this talk that I'll give right now will focus on racism and specifically anti-Black racism and white supremacy. And then after that, we can get granular in any direction you'd like. Another quick housekeeping note is that, of course, when I speak about patients or coworkers, just like in the book, I have intentionally changed identifying information. So let's start. So on this particular day in the ER, they just brought in 2 chest pain patients, and they are triaged as higher acuity. So I'm working with a mid-level provider, physician assistant that day, but higher acuity patients are seen by a doctor whenever it's possible. So I sign up for them both. I go to see the first patient, a man, elderly man. I'm concerned he might be having a heart attack. It's a good thing he is stable. So after evaluating him, I come back to my workstation, start entering his orders, and I see they've just brought in somebody whose heart rate on the monitor in front of me is a sinus tachycardia in the 130s. So she's not yet on the tracking board because she's brand new, but I'm able to see her room. It's a young appearing Black woman. So I'm thinking, well, maybe she's okay. I do need to see this patient, I think, is here for heart failure. And a lot of times when young people are brought in, their heart rate is fast, but they're fine. And by the time they settle in, it's normal again. So I go see the woman I think is having heart failure, who is also stable. I mean, they're both sick. Both the man with the concern for heart attack and this woman with heart failure will be admitted, but I have time to work them up, wait for the results, initiate treatment, come back to my workstation to enter her orders. Now I see the new patient is on the tracking board. They have finished her triage. She's marked as lower acuity. So the mid-level provider, Jason, I see is just walked into the room to see her. Getting more information now, I open her chart. Yes, she's young, a 31-year-old Miss Stewart, but she has some medical problems. She has high blood pressure, hyperthyroidism, and asthma. I look at the monitor, her heart rate is still fast. It's still sinus tachycardia 130s to 140. Her blood pressure is significantly elevated. So I'm a little more concerned because while she's young, she has comorbidities. My patients are okay. I'm waiting for all their results. So I walk by the room and I can see her speaking quickly and anxious, but periodically gulping for air. Her chief complaint is heart racing, shortness of breath, decreased energy. And I can see that as I'm looking at her. I see Jason, 40-year-old white man who's the PA for the day, standing at a bedside table looking at bottles of medications next to her. And so I ask him, how's it going in here? He looks up briefly to say, oh, I know her. She just doesn't take her medications, and continues to look at the bottles. And that made me angry for many reasons. One, that she hadn't been there that long. I knew it because I was monitoring the room. So there was no way he could have made this assessment that the only issue was that she was non-compliant. Angry because he wasn't looking at her. He was looking at bottles of medications and not her. Angry because that is literally the first and only thing he told me about the patient. I turned my gaze to her and she looked tired. The corners of her mouth were downturned. There was fatigue in her eyes. She looked like she was resigned and getting ready to collect her belongings and leave the ER in the same condition that brought her here. I was angry because he didn't recognize that she was sick and he had dismissed her with so little information, and that in our line of work, that indifference comes at far too high a cost. So I told him, you know what, I have some time now. I'll see this patient actually, and you can see whoever comes in next. So at that point, he summarily put down the bottles of medication and walked out of the room. I could see the muscles of her neck relax. Sorry. Oh my God. Sorry about that decline. Am I still sorry? I could see the muscles of her neck relax, not needing to brace against yet another medical rejection. And I say brace because of what I was about to find out from her. When I asked her what happened, she told me that the pandemic had been hard on her, that she was getting sicker, that she had thyroid problems. She was supposed to have gotten surgery, but that it was canceled due to the pandemic. She also told me that she had tried to reach her doctors. She called her primary care provider first, who said to her, you know what, this doesn't sound like it's an issue dealing with your general medical care at all. I think you should call your endocrinologist. He didn't see her. So she called her endocrinologist. Her endocrinologist said, I don't think this is your thyroid at all. I think what you need to do is call your primary care provider back. Her endocrinologist also didn't see her. She called her primary care provider back, who said, well, we could always just try a new medication. I'll call it in for you. Why don't you take it, see how it goes, and we'll take it from there. He didn't see her that time either. She proceeded to tell me about each medication. She told me the name, she told me the dose. She told me how she was taking all of them, including the new one, yet feeling sicker. She didn't know what else to do. So she came to the emergency department. I examined her. I saw that her heart rate was still fast. Her blood pressure was still high, that the muscles of her chest wall were working hard to keep her lungs filled with air, and that when she was trying to exhale, with each time there was a wheeze, constricting the flow, which was only making it harder. And her doctors didn't know this because they hadn't seen her. I asked the tech who I was working with that day to check her blood sugar. She didn't have a history of diabetes, but she was fatigued. She had one endocrine abnormality. I mean, you never know. Her blood sugar was critically high. This was new for her. So now, in addition to the blood pressure and the breathing, she may have a diabetic emergency. We didn't yet know about her thyroid. So I explained to her that short of a miracle, I'd need to admit her because the treatment for one condition could make the other worse. So it'd be a delicate balancing act, but we would address it in a stepwise fashion. And I just wanted to give her the heads up that I'd have to admit her because typically people need to make arrangements if they're going to stay in the hospital. And she said she was willing to do whatever it takes, that she wanted to feel better. And she did appreciate the heads up because she has 3 children. She's a single mother. And she was concerned about them. And she needed to make phone calls and speak to her mother so that her mother could care for them while she was here. And I thought back and I thought that I was concerned about her and her children. And I wanted her children to have a mother who was healthy and alive to take care of them. And I thought how I didn't know this woman for even 30 minutes. And certainly her doctors who knew her for years. Certainly I thought, shouldn't they share this same concern? And so these are the turning points, the places where lives can be lost, where they can be taken by people who don't see, who don't hear, who don't care. And whether it's due to implicit or explicit bias, it doesn't matter because the consequences are the same. And for many reasons, I've been at these crossroads myself at various points in my life when my health, my safety, my wellness were almost stolen because of structural bigotry or racism. And I'll start with an example from my childhood. And for as long as I can remember, I have enjoyed school. I've loved doing the work, studying for my lessons. And when I was little, I would do well in school. I would get the stickers and prizes and ribbons. And it was a good thing too. It was a very good thing. I felt that I did do well in school because for me, it was not just fun, but critical because I grew up in an abusive household with a father who was a batterer. And so from a very young age, in my estimation, in order for me to gain my freedom, my way out, my way to independence so that I wouldn't feel codependent and stuck like my mother, my way was to do well in school so that I could be in charge of my own life. So then when my third grade at the time, third grade teacher came to me and my mother and said, you know what, Michele is doing really well in this school. And this school has had all the tools she's needed to this point. But 4th grade, when she goes to the other campus, the other division, they don't have the same tools. So I really recommend you look into a different school that will be better able to support her for the next part of her education. And she, Mrs. Bunyan, I will never forget her name or her impact on my life, Mrs. Bunyan, recommended we look into a prestigious all-girls school in Washington, D.C., which my mother did. I took the entrance exam and did well on it and was accepted. So I was nervous about switching school. I was nervous about being in this all-girls school with uniforms for the first time, but I wasn't concerned about the work. And I wasn't even concerned about the social environment because I had no idea. I was coming from a primary school that was diverse. I was living in a part of Washington, D.C. that was predominantly Black and affluent. So I just assumed it would be diverse as well. I didn't know that at that point in 4th grade, lower school there, that I would be one of 2 Black students. I didn't know, I had no idea the myriad pressures and potential constraints that would entail. What I did know, though, was that it was a good school. And as long as I did well there, again, it would be my ticket out. So I started working in the same way, studying regularly at the kitchen table as I always did. But this time, when I got my test, there were no ribbons. There were definitely no stickers. There were no prizes. For the first time, I was not getting good grades. And I didn't understand it because when I was doing the work, challenging, sure, but I felt I understood it. So I went to my mother, heartbroken, absolutely crestfallen. I told her I didn't understand what was going on. She made an appointment with the principal. The principal, my mother told me years later, the principal started off the way that principals often do, saying, well, she's new. We see that with students who transfer in. It can be a bumpy adjustment period, but let's just see. Let's see what happens. Let's play it by ear and see, if she gets the hang of it, if it works out. At which point my mother said to her, are you tracking my daughter? So tracking has been a way in schools purportedly to group students into ability tracks. And the thinking is that no matter your ability level, if we group you together, then you can get the resources you need. So if you need special attention to certain areas, you will get it. If you're gifted and talented, same thing, you'll get what you need to excel. The problem is tracking has been used in different ways that are not positive. And studies have shown that it's been a way to systematically disenfranchise people who are typically systematically disenfranchised, which are actually most people because it's girls, people from lower socioeconomic groups, immigrants, people of color. So presumably when my mother said tracking, they heard legal issue. And at that point, the tone of the meeting changed. And the principal said, you know what, why don't we do something now to evaluate it? Why don't we bring in an independent test taker? And we'll just have, I know you took the entrance exam, but we'll just have her take another test, an independent test taker, and just see. We'll see if there are issues or not. My mother agreed. Again, I wasn't nervous for this test because I still like taking tests. I was uncomfortable with everything that was happening. I was uncomfortable with potentially being taken off my trajectory for myself, but the test was fine. And I remember getting ready for the test taking day. At that point in the lower school, we had 3 different color uniforms. It was either it was either blue. I love black actually now, but the uniforms were black, pink, or yellow with white pinstripes. My favorite was blue. I got ready for the day, did the school day, and then met with the proctor. What I remember is going page by page, categorizing colors and shapes and analyzing the sentence structure until I finished. And then I went home. My mother tells me that when she was brought back to be delivered the results, the principal started by saying, first and foremost, the proctor didn't even understand how I could finish the test because in the background, girls were playing, girls who hadn't been picked up yet from school. They were yelling, they were screaming, they were jumping and laughing, what sounded like backpacks being thrown against the hallway. And she said, but Michele never looked up. And I have to tell you, I don't remember the noise because I was focused. I was there to take a test. And what they didn't know, unfortunately, a survival strategy I had to master early was learning how to focus and survive through chaos. So I don't remember the noise. I remember the test. The principal went on to say that, well, in the midst of all that I had excelled on this exam too. So it didn't make sense because it didn't find deficits to explain the grades. And so after that, because I spoke out, because my mother had them name it, my grades magically changed. They changed to what I was actually earning. They changed to what was fair. And that's just one instance when I could have been derailed, where I could have become increasingly depressed so that I wouldn't have been there with Miss Stewart that day or with you here today. And interestingly and really tragically, I was the one who was tested. I was tested. I was examined. to look for the root of the problem, but I wasn't the problem. What I cannot tell you is what they did, if anything, to examine their practices, their policies, their procedures. And those were the problem. And so that's the thing. That's what racism does. Racism renders Black bodies problematic and so deserving of less. It makes them invisible and mute. And in that cone of silence, it steals them of their rights and labels those rights privileges. And it does more. It renders a racist person, or someone who's not anti-racist because they're the same, it renders that person blind. It causes them to collect unearned privileges and label those privileges their rights. So let's look a little more into this. Like, first of all, what even is race? Race is not essential. It's not real in that way. And when I say essential, I mean it's not a biological determination. We know that because we can see greater genetic variation within groups than between groups. What it is a way of categorizing people based on their appearance. And what it does do, in a very real way until we make different choices and change it, what it does do is influence one's experiences, one's access to resources, one's power. And in medicine and in public health, when we think about experiences and resources, we often talk about determinants of health. Okay, so now I will make the toggle to the slides. First tech challenge. Luckily, I don't have many slides. Okay. Oh, okay, it's working. Good. Social determinants of health. And when we speak of social determinants of health, we're talking about these different factors, such as economic stability. Do you have access to employment? Do you have fair pay? Are you saddled with debt, including medical bills? Your neighborhood, is it safe? Can you afford housing? Do you have parks where you can exercise and just enjoy yourself and your family and friends? Education. Is there access to education? Not only early childhood education, but vocational training, higher education. Food. Do you live in a food desert? Can you, we talk about eating healthy foods. Can you even access them? Again, can you afford them? Community, social context. Is it integrated? Or is there a lot of discrimination, stress? Are there support systems? And then healthcare. Do you have coverage? Can you even access healthcare? Are there providers to take care of you? And even if there are providers, can they communicate with you? Do they compensate somehow for a potential language barrier? And then this one's big, quality of care, because the truth is, even if there are hospitals around, if there are doctors to take care of you, what is the quality of care that you're getting? And what we know is that racism affects that. We know that, for example, treatment plans can vary based on race. That take something where there's no debate. Pain management for an acute significant injury. So I'm not talking about the subjective pain of, if you stub your toe. I'm not talking about getting prescription medications for chronic pain issues. I mean something unequivocal. You have broken your femur, you've broken your thigh bone, you're brought to the ER. Studies show that if you are Black, you are less likely to be given adequate pain medication, even in those circumstances, or cardiac catheterization that we know are life-saving procedures in acute coronary syndromes, certain acute coronary syndromes. Even in those circumstances, if you are Black, you are less likely to be given a cardiac catheterization. So it is then no surprise that the overall mortality is worse for Black patients. And we'll see some of these stats may change after the pandemic data shakes out. But so far, Black people die an average of 3 to 4 years younger than their white counterparts. And the statistics still, depending on disease process, these discrepancies are persistent. An area that's gotten a lot of attention is infant and maternal mortality. Maternal mortality for Black women, we're seeing that Black women are dying at rates 3 and 4 times of their white counterparts. Babies are not spared either. We're seeing that they're dying at 2 and 3 times, depending on the data of their white counterparts. And this is a graphic from the CDC showing those rates for different racial groups. There's some, they're kind of, in some of them, conflating them with ethnicity, which happens since race is made up. It can get confusing for some people. So we're seeing that on this slide. One study I always bring up, because it's so powerful, some of you might have heard of this study. The researchers Greenwood and that group of researchers last summer released a study. They wanted to hone in on race and ask the question, does the race of the provider influence mortality rates in babies? They were looking at, is there any racial concordance for these disparities? So what they did, it was really brilliantly done. What they did, they kept it simple. They looked at a group of white babies, Black babies, white doctors, Black doctors. It was brilliant because they looked at a lot of cases, almost 2 million, 1.8 million hospital births in Florida between 1992 and 2015. It was also brilliant because they're looking at babies when they're talking about racism. And most people cannot imagine wanting to harm a little infant because babies are inculpable and babies are perfect. And they remove the compounding variables of non-compliance because these are babies who are in a hospital. So you can't say that baby didn't show up for the appointment, so it's on the baby. The baby didn't take its medications. So, if the baby only followed instructions, you can't say that because they're babies in a hospital. So those variables are removed. And what they found was that for white babies, it didn't matter. Black doctor, white doctor, their mortality rates are the same. But for Black babies, it mattered a lot. And when their doctor was Black, their mortality rate was more than halved. It was decreased by 58%. So the researchers were wondering why. They asked the question, they said, well, what's happening with the providers? Let's look at the providers. But they found that the Black doctors were typically seeing more patients. The Black doctors were also seeing patients who had more underlying illness. They were also treating babies from families with fewer resources. So they didn't understand, because under these more challenging circumstances, still the outcomes for their patients were better. So the researchers left us to answer this question, us as doctors, us as humans in this nation, to answer the question, why is it that white physicians were consistently underperforming, but only when it came to Black babies? So we can see, and we know, certainly racism is bad for Black people. But I think we also know, just again, spiritually, emotionally, psychologically, that's bad for everyone. And there's some interesting research out of the UK. And these researchers, Wilkinson and Pickett, they looked at inequality, financial inequality in nations. And if a system is more unequal financially, if that affected, they posited the question, then did the research, if that affected healthcare outcomes there. This is useful because we know that kind of like STDs, inequalities like to travel together. So financial inequality can be a good proxy for other kinds of bigotry like racism. And what they found was that when they plotted similarly resourced nations on a graph, inequality versus index of social problems, that, yeah, it did bear out. The more unequal a society, the worse their outcomes were. And this relationship was maintained at every income strata, so that rich people in the US have worse outcomes than rich people in Norway, Sweden, Finland, other nations. And what are these outcomes they're looking at? They're big ones, they're important ones, like life expectancy, infant mortality, children's educational performance, homicides, rates of incarceration, social mobility, mental illness, substance abuse. Some data that, let me stop sharing this now because I don't have a slide for the next one. Hot off the presses is data from the Commonwealth Fund, so large research group in this country, who similarly looked at 11 richest nations. And they wanted to know, how are we doing? How is the US doing in this grouping of 11 richest nations in terms of outcomes? And they looked at care process, administrative efficiency, equity, access to care, and healthcare outcomes. Now, they did find that on care process, which is speaking to a patient about preventative measures, engaging a patient in decision-making, for example, on that, the US did really well. We were second. Kind of doesn't matter because on all the important ones, we were dead last. On healthcare outcomes, we were really last. And I wish, this is brand new data and I couldn't cut and paste it. I'm going to figure it out for next time, but it's remarkable. We're not just last, but they made the point, it was a little awkward plotting the US on the graph of outcomes because we were an outlier. We were so bad. We were so far away from the graph. We're also an outlier in terms of our spending. We spend much more than these nations. We do much worse. So we know inequity is bad for everyone. And it's because I feel that. I know that in an embodied way. It influences the way that I practice. So later that week, when a nurse yells out, "Get a stretcher, someone's been shot," we don our PPE to get ready for whatever. And I see a man walking in, I'm not really walking in, but limping in, being supported on his left side by a nurse and security. And he appeared to be a young Black man. I didn't have his demographic information yet. He was holding his right arm like a bag of broken sticks, and there was blood. There was blood everywhere. It was good that he was able to kind of stumble and moan in pain and speak. It was good that he was awake. It was good that although he was covered in blood, it wasn't spraying across the room or cascading down in floods. So we got him onto the stretcher. We cut off everything to fully expose him, figure out what's going on. I saw that he was shot. I could certainly see he was shot in his arm. I was asking him what happened. He knows that he was shot. He knows that he had fallen. He couldn't remember all the details, which is understandable because being shot tends to narrow the mind. I look at his arm. I see it's deformed and bent in angles that defy nature, that defy physics. I feel for his pulses, the two pulses at the wrist. One is bounding and normal. The other one is thready, which is a problem. I don't know if I can fix it by reducing his arm, but I know I have to try. So I explained to him that we're going to fully evaluate him. We're going to give him pain medicine. The nurses are getting an IV and they're getting the pain medicine that I've ordered. But I also said we can't wait for that, for me to reduce his arm, which means pull on his arm to put it back in place, because I have to see if I can fix his pulses so that he can keep his arm. So I say to him, is it okay if we just do that now? And I promise you, you'll get pain medicine. And he says, yes. The tech I'm working with stabilizes him, holds his shoulders back on the stretcher because I know he said yes, but he doesn't exactly know what this is about to feel like, but both of us do. And I pull on his arm and he screams, and I hear and I feel crunching of his bones as it's put back into a shape that now approximates an arm. And I feel his pulses and they're now normal, thankfully. And we put him in a splint and he gets the promised pain medications. And I tell the nurses, please take him to CAT scan now. Please let the CT tech know that I also want them to get a CAT scan of his arm with IV contrast to look at the vasculature. And no, we are not waiting for labs. I just want it done now. They take him. We stabilize him. I'm not at a transfer center when I'm working with this patient, so I make the appropriate phone calls and get him transferred out. Days later, one of my colleagues a white woman who I work with, asks about the case. Interesting cases, we often discuss them in the department and people can hear about them. And she said to me, why did you CAT scan his arm? I mean, I know you need to do other CAT scans, but why his arm? Because you fix the pulses and he's going to be transferred out anyway. They're going to do surgery anyway. You could have skipped that part. And I was actually kind of surprised because I had never thought about it. I didn't. It had never occurred to me that I could skip any step or take any shortcut. Because what if in the process of transferring him, what if in the game of telephone, somebody didn't know that there was initially a problem with the pulse? What if because they didn't know and he arrived fine, there was a delay in diagnosis? What if he ended up permanently disabled as a result? What if he ended up losing his arm needlessly as a result? Well, I can tell you, we had the CAT scan. I ended up getting the CAT scan results and his vasculature was fine. And the hospital we transferred to, they always contact us to give us an update on the patient's status. It's professional courtesy. And I was informed that he was taken to the operating room. He had an uneventful surgery. He recovered while in the hospital and was discharged in good condition. And as for Miss Stewart, that day I did have to admit her to the intensive care unit. She had hypertensive urgency and asthma and diabetic ketoacidosis. Everything got better with medications for each process, and she was discharged home in good condition on a new medication regimen. That's the thing. I couldn't leave his arm to chance, just like I couldn't leave Miss Stewart's health to chance, just like I couldn't leave fourth grade me to chance. Because again, I knew it instinctively. I know it from what I've experienced, from what I've seen, from what all the studies repeatedly demonstrate, which is that the effect of racism is being unseen, unheard, and disregarded. And that the intention doesn't matter. Again, the intention doesn't matter because the outcomes are the same, and it's the outcomes that matter. And I already know that most people who are racist don't identify as such. And that racism allows, it in fact encourages for them to go unexamined, unquestioned, especially when, and most importantly, when it comes to self-inquiry. So it's not until I work in a field where everyone is seen truthfully, and I live in a country where everyone is treated equitably, that I can rely on the assumed good graces of others. So what are the solutions? Okay, so those solutions are what everybody always says. They're right. They're all the same. They're true. The solutions are that we need diversity in healthcare providers. We need equal access to quality healthcare, to education, to healthy environments. We need research and data on disparities. And that being said, we currently have reams of this data. We know it's a real thing. That's a problem everywhere that exists. So it's not that we don't have the data. We have the data. Okay. However, it's a good idea to keep collecting data. We can at least see how we're doing over time, how we're doing as we do or don't address the disparities. And maybe all of this will increase awareness, and that's important. We also need accountability. Accountability is critical. That's something that's underutilized. I've said that I've faced structural bigotry many times. A more recent time was when I was new attending physician. And I just graduated, recently graduated, and I love seeing patients, but I wanted to do more. I was used to leadership positions. It's my well-worn groove. Remember that school I went to in fourth grade? It's 4th through 12th. And I will say that it got better over time. The class size expanded, it became more diverse, and it became a part of my life that I cherished. And I'm really grateful for my experiences there. And in my senior year, I was school government president. In residency, I was one of the chief residents. And now as an attending, I thought, well, maybe I can do more if I'm in an administrative role. I can have a wider range of impact. So a hospital position opened up, and I threw my name in the hat and went through the series of interviews. I enjoyed them. I like meeting new people. I like talking to new people. It was fun. And then I just waited. I waited for my ER director to call me into his office for the time when he would say, Michele, you have gotten the position. But instead, what he said to me was, oh, Michele, you're so qualified for this job. You did so great on your interviews. But the hospital, they've decided that even though you were the only applicant, they're just going to keep it open for now. It's just not the right time. And he went on to say, I hope you stay. I hope you stay on with us. Because the thing is, this hospital doesn't promote women or people of color. They just don't. So they always end up leaving, but I hope you'll stay. I submitted my letter of resignation and I did leave. And because I still knew people who worked in the hospital, I did find out that not long after, it was apparently the perfect time to hire. And so they did hire, and they hired a white male nurse for the position. And this is why I bring up how accountability is so important, because you don't actually have to care about equity in order to be held accountable for violating civil rights. And so what will all of this take? All of these steps are important, but to get there, we have to do something so much more fundamental. And what we need to do, what it will take individually, is a personal shift. And we don't need everyone. We just need a critical mass of people to commit to this personal shift. And this shift has 2 easy steps. One is to be honest. We have to be honest that we live in a racist society. Now, we don't have to. Racism is a learned behavior, and anything that is learned can be unlearned, can be modified. It's a good thing. The other thing is to act from a place of honesty and integrity. Because, Angela Davis is right. She was always right when she said, in a racist society, it is not enough to be non-racist. We must be anti-racist. And what does that look like? Okay, I'm going to get to my last 2 slides. Whenever one is faced with a life conundrum, one can often turn to Audre Lorde for the answers. And so I turn to her again here for this one. What does it look like to be anti-racist? Just a quick note, in this quote, she uses the word woman. And certainly for this essay, in her discussion, she is speaking to and about women. It's applicable. It's also generalizable to everyone. And of course, I have to say that because we haven't yet, smashed the patriarchy. So in this quote, women is applying to women and men. Okay, my last screen share. Okay. And so what it looks like, I have to minimize this because it's cutting it off for me. Okay. It is learning how to stand alone, unpopular and sometimes reviled, and how to make common cause with those others identified as outside the structures in order to define and seek a world in which we can all flourish. It is learning how to take our differences and make them strength. For the master's tool will never dismantle the master's house. And this fact is only threatening to those women who still define the master's house as their only source of support. And I always leave that up there for a second because you need a moment with that quote. It is so powerful and so accurate. And it's when we do that, when we can embody that, that we can have health equity. And what health equity looks like, the definition that I love from the Robert Wood Johnson Foundation. There it is. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and the lack of access to good jobs with fair pay, quality education, housing, safe environments, and health care. Stop share. So it is my hope that we are women and men of insight who have the skills of discernment to recognize truth and facts. I hope that we choose to have that courage, not simply in our thoughts and prayers, but in our daily lives. Which brings me to my final word. You know, we are living in a time of unique circumstances. The pandemic has laid bare disparities that have always been there. Disparities that are most harshly felt by the most vulnerable among us, the most vulnerable being anyone who's not rich. We are seeing increasingly the disparities in access to care, the abandonment of frontline workers. And when I say frontline workers, I'm talking about people in the gig economy, minimum wage workers, people who work in mail delivery, store clerks, bank tellers, all the people who have gotten us through, who have kept our lives going through the pandemic. And when I'm talking about frontline workers, I'm also talking about physicians. I'm sure it is lost on exactly no one in the audience that for the first time, healthcare providers and doctors are finding themselves unemployed and underemployed, unable to find jobs. You know, it's because this profit-based healthcare system we have does not work. And it's part of a larger pandemic of structural bigotry. So colleagues, this is what we're up against. These are some of the greatest questions of our time. Who are we? Who is it we want to be? And what actions are we taking to that end? You know, I sit, because this is virtual, I sit before you as someone who loves the essence of humanity. I love caring for patients. I love serving actual healthcare in the ER, and increasingly through my writing and speaking. And I know that as the hours, the weeks, the decades unfold, you will know your path. And this path, if you are willing to answer the call, will unfold in ways you never could have predicted. And it will be exhilarating and terrifying and fulfilling. And so I wish you wonder on your road. I wish you magic too. And more than any of all that, I wish you radical honesty and the courage to live with integrity so that you can answer these questions for yourself in your heart and with your actions. Onwards. Thank you.
Thank you so much, Dr. Harper, for that talk. I think I speak for everyone when I say that so much of what you said was extremely profound and it resonated with me so deeply. And again, I'm sure everyone who's listening right now feels the same. Thank you again for being here. Right now, we're going to open it up a little bit into a Q&A. Katya and I have some questions already prepared, but also for those listening, if you want to put questions in the Q&A chat, or I think if you're watching in the Met Auditorium, you might be able to like unmute yourself and ask a question on your own. But if it's all right with you, I have a question to start it off. So one of the things that you said just now that stood out to me so much was when you were speaking about being in fourth grade and taking that test. You said, I was the one being tested, but I was not the one that was failing. And I think that that applies to so many things. And you did talk about this with talking about the social determinants of health and healthcare disparities, but I would love if you could speak some more about how this idea manifests for minorities or the Black community specifically on a larger scale in the US or in regards to patients within our healthcare system.
And it's really, unfortunately, everything and every day. And I can tell you that as an ER provider, and I'm sure you'll all see it in your fields, but I find that I typically have to advocate for my patients and myself, whether or not it's a woman who comes in who is a different patient, short of breath, couldn't breathe. I had done every test on her, looking at her heart, her kidneys, screening for blood clots. I couldn't find anything, thankfully. Her lung sounds were normal. She didn't have a history of asthma, didn't sound like reactive airway disease, but she said she really just couldn't breathe. And I believed her. I just didn't know what was going on. She walked to the restroom. When she came back from the restroom, thankfully, her nurse said, "You look like you're having a tough time. Let's check your oxygen." It was dangerously low. She's right. We didn't know why, but her oxygen was going dangerously low. I was going to admit her. I'm not going to, although I don't have a diagnosis, I know something is wrong and it needs to be addressed. I called the hospitalist to admit her, and he said, "I've already reviewed the chart. All the data is good. I'm not admitting her." And I never in my life, I've not been denied such an admission for anyone else. I mean, this is a young Black woman. I admit people all the time of different demographics who can't breathe. This is the first time I've ever been told that. I had to fight to get her admitted. And I told him, listen, we're not going to have this argument. You don't want to admit her? Okay, I'll call other people to admit her. Because this was only going to end one way for her, with her getting the care she needs. And this happens, unfortunately, a lot. It plays out in that way, one-on-one, the patient in the ER. And then, of course, as we talked about the data, it plays out with Black women having higher mortality rates in pregnancy, with the recent case of even the doctor. I think you probably heard of it. There was a doctor who was critically ill with COVID, struggling for help, repeatedly being sent home, ignored, denied. She died. It plays out on every level, which is why part of what's so important for me is to, yes, take care of patients one-on-one, but then to do the advocacy work. And sometimes that means doing it outside of the House of Medicine. Sure, it's great if you can change policy in your hospital. It's fantastic. It's important if we can change policy on a larger level. What I've seen because of structural bigotry is that we also have to partner with people outside of medicine, because within medicine, we don't have the numbers. This is going to take a concerted effort. This is political in that it matters who we elect. It matters if we decide to run for office. It matters when we vote, because this is going to take change, require change on every single level. And that's also part of the reason why I decided to write, because it's amazing. It's amazing when you have a New York Times bestseller book, the people who all of a sudden want to talk to you, who never wanted to talk to you before. So it's about being creative, how we address these concerns. And even though I talk about really serious issues, even though it can get overwhelming and depressing, even though I promise you this is a life work, there is no quick fix, it's also possible, and it's fulfilling, and it's worth it. I will also warn people, because I tend to ramble. Feel free to ask follow-up questions. Feel free to redirect. I know we have time later too, so that's fantastic.
Yeah, I thank you for offering for the follow-up questions. I think that in what you were just saying, it's something I've been struggling to think about recently, and that there's both this feeling of we want change to happen, right? Mm-hmm. And these movements are moving and then they feel slow. And there's both the need for the patients on our end to understand that I can't just wake up one day and decide that I'm going to be fixing the rest of the world and everything is going to be okay after that, that it takes time and effort and this consistency, right? It's not just a flash in the pan summer movement and suddenly we forget about BLM, right? It's that we are consistent over time about it. But there's also this feeling of it almost traps you in thinking that if change is going to take so long, it's exhausting. And it's no, there are so many things that we could do now, that we can change now. And so in that context, I wonder what you think, how our current systems of power can really make space for that change on their end, right? People in leadership positions, what are the things that you can look out for when you're in the room with someone else? How do we uplift those voices?
Yeah. And I like how you put that, because it takes action, and it will take claiming your rights and your power, because a lot of people just don't give power away. So what it will take is, and I always say this, my answer to this question is always the same. I think that it will take courage and honesty. And so the courage to open our eyes and hearts and be willing to see what is in front of us, right? We all know the circumstances when someone's in a bad relationship, right? Like their boyfriend or their girlfriend is trash, but they don't want to see it. And so they continue, right? Like it takes courage to be willing to see it. You know, there are harder times. Like this is hard. Like this is our life's work, right? You know, we all probably know someone or have treated the patient where they have cancer. That's a hard diagnosis. They are not ready to look at it or have the discussion. You know, and so in many ways, they're analogous to what we're dealing with. And it's not a small thing to have the courage to realize the deficiencies of the system we're within. That's huge. Fine. So once we do that, yes, it'll take educating ourselves, like reading about these matters, having open conversations with people, educating ourselves, and then acting in small ways in how we treat each other and patients. And then, yeah, when we witness injustice, you know, there was a time when a patient was calling me racial epithets because she wanted confidential information about another patient who like wasn't even in the department, so we couldn't get consent. And I explained to her, I cannot give her confidential information about a patient, and that's it. There's nothing else to discuss. So she starts calling me racial epithets, saying she wants to speak to my manager and report it. Yeah, this was what happened. And one of my colleagues that day, well, first of all, I will say, none of my colleagues spoke up in that moment. They should have. That would have been a small, easy way of making a difference. One person kind of spoke to me afterwards and also contacted the director to say, you know, there was this racist incident in her way to do like damage control later. So I give that as an example of like small ways in the moment to stand up, because the burden, you know, for example, the burden of stopping hate crimes against Asians is not for Asians to bear. Like that's for all of us to do, right? The burden of stopping hate crimes against LGBTQ community is not just for them. Like that's for all of us to do. So there are ways we can step up in a daily basis. And then of course, the larger policy work in terms of in hospitals, who's hired, who's promoted, who gets a seat at the table, what happens at that table, and having accountability for all of that.
I think that was beautifully said. And one of the most frustrating parts of the story you tell about applying for this position is that man looked at you in the face and said, like, I know they're doing it wrong, but that's all there is to say about it, you know.
That's all there is to it. I know. And sat back down in his comfortable chair. You know, his effort, as I say in the book, his effort was complete. Yeah, it's a problem. That's why it continues.
Okay, and we have a question that was submitted, a very succinct question. I think it's just asking for your general opinion, but how do we move away from a system of profit-based healthcare?
We have to demand it. Seriously. It is a matter of demanding it. This is another instance where we literally have the data. This is, I swear to you, we have this collective delusion in this nation where we're like, for some reason, we are willing to advocate against our own interests. For some reason, we've bought into this idea that employee-based healthcare healthcare you have to buy in the private market is okay. It's like legit not okay. we have no data to support it being okay. We perform the worst. I will say, I've spoken to some people about this, and there are a lot of people who aren't aware of the deleterious effects of it. So I think part of it is getting the information out there. And then, of course, coupled with the action, and we just, the people who are in positions to make policy, which could any day be some of us, probably some of us will run for office. And so when we vote and when we have people in decision-making capacities, we have to demand from them that, guess what? We want healthcare for everyone, like every other rich nation. It's not a diagnostic dilemma. It's not some unsolvable puzzle of how to get it done and make it work. No, it's quite literally been done in many regions in the world, and it works. And we could do it too, if and when we actually value healthcare, we value the lives of the people in this country, and all of them, not just the ones who are wealthy and influential.
Yeah, I heavily agree with that. I think that, you kind of discuss all of these other social determinants of health, right? Bringing up socioeconomic status or race and all these different things we see. We all know that there are so many social determinants of health that are outside of our control in the hospital. And I think that that's kind of a big struggle for us, is to understand, knowing that a patient who comes in who has asthma because they live in an asbestos-filled housing unit, and there's nothing we can do about that, or knowing that our patient needs a particular type of care that they simply can't afford, whether it be insulin or some kind of surgery. So how do you cope or advocate against knowing that there's a limit for how much we can do to help our patients, right? Because we're constrained within this hospital system.
No, you're right. We are working within constraints. And so, there enter realism at the same time. Part of the way that I cope is I chose a field where I cannot turn anyone away. I honestly, God bless everyone who works in clinics where people are turned away unless they have a $500 copay just to get in the door. I can't be that person. And I understand those are terrible constraints, and it's not the fault necessarily of the individual provider, but I can't. So that's part of my coping mechanism, where I work in a field where I have to take care of people. And if there's an emergency, I am allowed, because I'm an ER doctor, to do whatever study I need to do, and I don't have to get pre-authorization for a study or a drug or whatever. So that has helped me. We can talk about the issues with emergency medicine later, but that part has helped me. But then also, because there is only so much I can do, and because often when I take care of patients, when they're stabilized and leave, I have to say a little prayer that somebody will see them in clinic. I have seen patients come back and ultimately die of treatable cancers because they can't afford to see an oncologist or interventional radiologist or surgeon. I've seen people die because the only place they can walk in and be seen is the ER. So my answer of how I can cope with that part, besides all the self-care stuff I do, is this part, is doing advocacy work through my writing and speaking and trying to build awareness and make change on a larger level that way. That's how I can stay in this field.
I would at some point love to hear your thoughts on EM as well. Dom and I are actually medicine.
We'll talk about it.
Very similar reasons, I used to work in Bellevue in New York.
Yeah.
And so it's, public hospital, you've got all kinds of patients coming in. And it also means, there's a lot of experiences like the ones that you described in your book, where it's really tough for you as a provider. It's tough for you to stand in the face of people saying awful things to you, people being violent towards you. And I'm wondering, kind of in those moments, how do you maintain yourself? How do you maintain your identity and bring yourself to work so that you're kind of most optimized to work with patients and heal them, because that's what we're here to do, but also be yourself and hold on to your humanity?
So I will say, typically, I've worked in a lot of different environments. I tend to choose, and so the majority of places I've worked are places that don't have as many resources. So, I like cities. So I tend to be in cities, lower financially resourced areas, predominantly Black and brown immigrant, places where like half of my day is in Spanish. So, and I will say that's what just lights up my heart. And clinically speaking, that's where I'm happiest. And I will say, what I felt to be the most dangerous places I've been in for me as a provider have been more affluent, predominantly white. Like that's where the one place I was punched in the face was in South Philly in Pennsylvania. Luckily that was the only time. And the places where I faced like the most like sexist and vitriolic racism have also been in more affluent communities. So I guess it kind of works out that I like these other environments because I've been safer there. Okay, so that being said, so how do I deal though with the stresses of this job? And there is a lot of danger and there are a lot of unknowns. And we know that violence against healthcare, it's one of the most physically dangerous jobs, working in a hospital and specifically working in an ER. So how I cope and how I handle with that is that I feel I need to be there. I feel I need to be there to help people in crisis when they feel they may be in crisis actually, but whether or not they feel they are in crisis. And so in that way, it's a calling. And I resonate more with the title of healer than doctor specifically. Anyone can be a healer, like an artist, a plumber, an electrician, doesn't matter. Like if that's your calling, if you're doing acts of service, then that's just what you need to be doing. And that's where you need to be. So in that way, it's rejuvenating. But then also, because this work can be very depleting, mainly because of the constraints of the realities of the US healthcare system. So it's become increasingly important for me to invest in my self-care practices, like yoga, meditation, healthy eating. Also, like having a clean life, which also means detoxing the people I allow in my life and just cutting ties, like go with God. I wish you well. No hard feelings. You just can't be here. So that's been very helpful, but also doing other work in the name of healing. And I'm not joking. I couldn't have really guessed, and I still can't guess where these roads will lead me, but I know I have to follow them. And so it's important that I have this whole other non-clinical life. In the ER, I always say I can help one person at a time, potentially a family or community at a time, but with writing and speaking, that transcends borders, even national borders. So I find that even though my schedule's super crazy and I have now 2 full-time jobs, and the medical one is like reliably keeping the lights on, although there's nothing reliable about medicine right now. But even though there's 2 full-time jobs, it's engagements like this that really keep me going. When I leave an ER shift, I'm depleted. Like I have to recover from an ER shift. When I finish speaking events or publicity engagements, I'm amped. Like I can then go into work or then do my yoga class. So it's that combination of just mindfully following and being receptive to my path.
Yeah, so I think you've done such a great job kind of redefining the idea of resilience, especially on a personal level, and also speaking about how important it is just to show up for patients and to kind of bear witness. And we have another question that was submitted kind of asking more about that. Just what advice you have to support survivors of any kind of trauma as a healthcare professional.
And that arrives in different ways because we're seeing people at different points. And I think part of it is just being open to the fact that there are times when we meet people, everybody wants to be treated with respect. Everyone wants their immediate physical concern addressed, and in a way that doesn't add more trauma to the emotional, psychological, spiritual. So there's that part of doing that. But then beyond that, a person may or may not be ready to take steps for themselves. So, I can think of a woman I saw who had pain and swelling in her face. She wanted evaluation for it, like all over her face. It looked like she had been beaten. And when I asked her what happened, she told me she was playing softball and the softball hit her in the face. And no, she was not in danger. Nobody had hurt her. She just wanted to know if anything was broken. That clearly was not the mechanism of injury. There is no way in the world a softball bounced all over her face. It didn't happen. And, I explained that, of course, and we're going to need CAT scans given the extent of her swelling and tenderness and pain. I was also, after, I examined her and said we should get CAT scans, I did say to her, I have to be honest, I am concerned because it does not look like this is a softball injury. And I've been doing this a while. And what it looks like is that someone has hurt you, that someone has beaten you. And if that is the case, we have resources. I'm only asking because I want to make sure you're safe and provide you with resources for help. Would you like those resources? And she shut it down and was like, no, that didn't happen. I don't need any resources. And I said, because if you would like to speak to the police, file a report, if you would like information for a social worker, for safe housing, if you need us to admit you here because there's no safe place for you to go, I don't want any of it. It didn't happen. I don't want any of it. I don't need resources. I don't want to talk about it. Done. And so that's it. That was the extent of the conversation. She did have multiple facial fractures. We got her the medication she needed, the follow-up she needed. We didn't address any of the rest. She didn't want to. And I think we still gave her some information with her discharge papers though. And I think part of helping someone who's survived, trying to survive, healing from trauma is also respecting where they are at that time. Because she was a fully grown woman. She's not a child. She wasn't mentally incapacitated. She wasn't elderly. So it wasn't a situation where we have to take away her rights and just assume them for her. So I had to meet her where she is. Alternatively, I had a situation with a woman who brought in her child. The child was like a teenager, 16 roughly, who was anxious, super anxious, couldn't figure out why. She had previously been in therapy, but not recently. She wasn't doing well in school, though she typically does. the mom knew there was pretty much nothing we could do in the ER, but she didn't know where else to go, so she came here. She didn't have an appointment with her doctor yet, so she came here. So I spoke to the teenager alone, and I explained to mom and her that I often interview children alone just to get more information, to do safety screenings that we can't initially do with the parent. Mom was like, fine. She left the room and we spoke. And that's when the patient told me that she's actually been anxious ever since she was sexually abused by a relative. And that relative no longer lives in the country. She's not around her. She is safe in that respect. But she said when she had told her mother about it years ago, her mother said, that didn't happen, and I never want you to tell me about it again. And she said that as a result, she's never brought it up, and she knows that she's suffering from it, and she doesn't have anyone to talk to. So I explained to her that, in certain situations, like with abuse, it's very important for me to have that conversation with the parent, potentially other people too, that we have to break confidentiality in that way to ensure that she's safe. So I asked her, is it okay if I speak to your mom about it? I mean, honestly, I had to do it anyway, but still, I asked her if it's okay. And she said, yes. And she said, actually, please do, because maybe if you tell her, she'll finally believe me. And I brought the mom back in and we all had the conversation together. And the mother broke down and she apologized and she explained how she felt terrible. She apologized to her daughter. She acknowledged the truth of it. And she said that she was abused when she was young. And she just think that it was very triggering for her. She couldn't handle it. She didn't want to believe it. Long story short, we made sure that both of them were safe individually and also as a family unit. I mean, they were, from what I gathered from the interaction, they really did care about each other. And they were in a safe place now. And they were both going to follow up with services for counseling individually and together. The daughter felt relieved. She felt like there was a path forward. And so that's a different example where these were two people who were ready to face the adversity and heal from it. So part of what we do is just either way, make it a point to not interact in a way to cause trauma. And then we just meet the people where they are to see what resources can be employed at that point.
Thank you for that extremely insightful answer. And I know that is advice that we can all carry with us and keep in mind whenever we find ourselves interacting with any patient. I have another question for you. One, reading your book and listening to you speak right now has been so surreal for me, especially because I am also a Black woman and I'm extremely interested in emergency medicine. And so much of what you've said and the experiences you've shared and how you felt about certain things, so many things resonated with me, or I found, common shared experiences or feelings in that. And so again, thank you for sharing and for giving your testimony to the world with your book. And one of the biggest questions that I had after finishing the book was how you kind of reconcile all of these different identities that you hold as a physician, as a Black woman, as an author now, and kind of in what ways do those identities kind of conflict sometimes, or how do you reconcile some of the privileges that you gain from being a doctor that you otherwise would not have as a Black woman? And if there's any times, or how do you ever feel like some of the privileges that you've gained kind of inherently distance you from other identities, like being a Black woman, where you wouldn't have those privileges?
I will say that something that's helped me and really anchored me in navigating all of this is I'm not religious. We all have our own things. I'm spiritual. And so that's really anchored me in terms of identifying for myself what's most important. And I identify, like I'm wearing an Om sign. I identify with a lot of like Buddhist beliefs, again, not religious, but so because I don't identify as much with like form and I'm less materialistic in that way, and what I identify with is a mission, the mission of the work that I'm here to do. So that has helped me, like it's less confusing in that way for me when I think about my various identities in physical form, like whether that's being a woman or Black in America or a physician or an author, because at the root of all of it is just my calling to be in community with people, to do positive work. So because I always hold to that, then it's unifying. So then the rest doesn't matter. So that's been I think that's really, oh, wow. That's just how I navigate. Thank you for the question. That's just how I navigate it. And then it's interesting to me to look through these different lenses. And yes, of course, I'm treated differently depending on the space that I'm in. So I try to just be curious about it. I will say, technically speaking, being an ER doctor and then having this kind of public part of my life is so strange. I mean, I can say this to you all because you'll appreciate it, because so much of what we do as healthcare providers is private and there are boundaries, and it's important to have those. I will say I'm actually a little grateful that I launched this book during a pandemic because we have masks. So there's a certain amount of anonymity. So it's really nice. And also I tend to, work in like places that aren't cosmopolitan. So people rarely know. So it's, every once in a while, like recently someone brought in a People magazine and was like, wait a second, that's you. But because of the masks and everything, I've been shielded from that, which for me as a doctor is useful, because I don't want anything clinical to be about me. Like I'm there doing a work, taking care of other people, being part of a team. And I want that part of my practice to be maintained. So practically speaking, that is something that I've been thinking about increasingly. But so far, thankful for masks. See, masks are good. I'm thankful for that. That's a good thing. So I hope I answered your question.
Yes, you did. Thank you so much.
So I do want to remind the students that are in the Met Auditorium right now that it is the open question time. If you do have a question, you can pop up to the front microphone and ask. But otherwise, I'm going to read a question off of the online Q&A, which says, "Hi, Dr. Harper. While reading your book, I really appreciated moments where you stood up to your colleagues to stop systemic racism. As we progress on this journey as medical students, I imagine we may encounter colleagues and superiors, residents, attendings, etc., that may act on racial biases. How do you recommend we navigate these situations given the existing power dynamics in medicine often consider student voices as less important? Do we call people out or try to intervene directly?"
And that's a really good question, because there is a very strict hierarchy in medicine, very strict. So there are actions I take now as an attending, which still are kind of perilous because attendings can be fired and reprimanded and their lives can be made miserable. But there are actions I can take as an attending. There are actions your chiefs can take as chiefs that I'm just going to be honest, I would not recommend you do as a student or a first-year med student. So I would say sometimes, we leverage the power that we have. The more power you have, the more you can do. And sometimes if you're lower on the totem pole in the medical hierarchy, if it's not a life-threatening situation, there's all that is thrown out the window if there's an immediate life threat. Of course, you intervene. Just, it's a good thing to do. It's what people do. But if it's not an immediate life threat, it may be most strategic to speak to one of your seniors, or maybe you get a group of students who all agree, or first years who all agree, and then you go to someone who has more power than you to address it. I'm just, it almost pains me to say it, but I'm really trying to be honest with you, because it's important to take these actions. It's also important to do it in a way where you can go on to help many other people. And you can't go on to help many other people if your career is ruined, if you are like blacklisted and you can't progress. Let me try and anchor this in an example. Gosh, in the book, I give examples of where there was a patient brought in police custody, and the patient didn't want to be examined. He was youngish. I mean, whatever. To me, anybody who's like 30 years and younger, every year that number goes up, it's young. Okay. So he was a young Black man in police custody. And the police said that they had brought him there for us to get the drugs out because they had alleged he'd swallowed bags of drugs. The patient did not want to be examined. He did not want to be there. I had a resident who went over and said to the patient, he didn't have any rights. This is what we're going to do. So that would have been, if we did that, that would have been certainly unethical and unprofessional. It also would have been illegal. It would have been assault. So I intervened, and because I was the attending, so I can do that. And I took the case over and explained to everyone that he has rights as a person in America, reminding the police of the law, the police who didn't have a search warrant or any reason for me to violate this man's rights, and also the staff, and discharged him because he was competent, sober. There was no reason for me to break the law. So as an attending, I can do that. If there was a med student, for example, say I wasn't around, I don't know, say I was in a pediatric code and I just stabilized it and I was just leaving the room. If there was a med student, I don't think it would have been appropriate for the med student to intervene in that interaction at that time, but it would have been appropriate for them to come to me and say, this is what's going on. Like, I know you don't know about it yet, but you really need to get over there. You have to take care of this. That would have been completely appropriate. And that would have worked within the hierarchy. And if it had been handled differently, for example, it could have potentially escalated because chain of command was broken and this already inappropriate resident might have just lost it. So that's just an example where there are ways to address inequity that still respect the chain of command. And right, wrong, or indifferent, because I'm not this person who's necessarily about hierarchy, especially when it's wrong. We do have a hierarchy, and so we have to kind of artfully navigate it. I hope that makes sense.
It does. And there's actually one more question that's kind of a different variation of the same question, but gearing towards women in medicine. Data shows that 40% of women physicians go part-time or leave medicine within 6 years after completing residency. Do you have any advice specifically for women in medicine?
Well, I think a lot of advice. I think in general, I think women should do what they want. But unpacking that, it is important to know that we're following our own story and not a story someone gave us. Because I do see a lot of people, and there are a lot of people who are in medicine, for example, who all of us know these people. And some of us are these people where we're in medicine because it was the dream of our family or social circle, not necessarily ours, but it was thought to be prestigious at a time. I think that's changing, but it was thought to be prestigious. So we're living someone else's dream. I think the same goes for women specifically, where we may be in medicine for that reason, but we may also cultivate our career for that reason. We may choose partners who don't honor our work and our time. We may allow our partners to say that, sure, you're doing work in a hospital, but guess what? You're going to do full-time work at home too. And I'm not going to help because, rah, rah, patriarchy. Like that's a real thing for many professional women. I mean, the good news about that is, people might get mad when I say this, but the good news about that is it is a choice. It is a choice if we give our power away in our personal relationships. And I say it's a choice because I'm speaking to people who have an education. I'm speaking to people who are very intelligent, who have careers. No matter your status in this country, you have some kind of legal status in this country. So I am speaking to people who have a certain amount of privilege, and this is not true for all humans, but to the group who are sitting here having this discussion, we do have the privilege to choose our relationships, to decide what we'll accept from those relationships. And often I see a lot of women making choices to give their power away. But do I think that healthy relationships are possible where they're literally partnerships, and then you can make healthy decisions with your partner or alone, doesn't matter, how you want to live your life. And you can decide if you want to be full-time. You can decide if you want to be part-time. You can decide if you want a child or not. All of that is possible when women claim their power. And then, of course, it's still part of this structural inequity thing where, yeah, we have to address the pay gap. We have to address the disparities in hiring and promotion, again, pay. It's all part of the same process. It's very hard, though, to address that if and when we allow ourselves to be in toxic relationships.
Thank you. I think, a lot of what you've spoken about is about the personal level of control that we can take, because that's really the place we start from. I think it was in, oh gosh, what's that book? Man's Search for Meaning. Have you read that book? Viktor
Heard of it.
Frankl. Viktor Frankl, and he references this line about how the greatest freedom is the freedom to choose how we're feeling about something, and that sounds similar to kind of what you're saying. I do think, of course, that there are a lot of structural changes that we can make, and I think that that's another point at which we can recruit other people who, like in this case, like men who do have the privilege to potentially advocate for these policies that would be protective of women. I also was thinking about how these stories that you tell and that come up, I'm sure there are many that you didn't tell, and many that impact you. And I kind of wonder, do you constantly reflect on your experiences with your patients, or was it kind of like you came to write this book, you came off the administrative ladder, you decided to go into authorship, and you sat down, you realized all this stuff, or has it been kind of an ongoing process for you?
I think it's an ongoing process of reflection. The book was possible because self-inquiry and reflection is important for my life and my growth. It's just how I live. Now, I will say, because I'm an ER doctor, we see so many patients, so many, and a book is obviously highly curated. So I could pick the ones that were most memorable to me that also fit with the arc of the story. So, if there are 12 cases in here, it's out of thousands. So that is one thing that kind of makes it easier given my line of work. But part of my personal practice as well is after days or weeks, I mean, I do try to reflect on what has happened, how I felt about it, what could be like, what are some of the issues, where I could have improved, where I might have excelled. So it's just kind of how I live.
Definitely. It seemed like you were picking these stories to help also weave in these moments in your life when you were having these revelations or going through a particular thing that felt mirrored with your patients. And I think the story you were telling about the autonomous patient and the annoying resident was in the same chapter as receiving a letter from your father and having that letter like sit in your bag.
Yeah.
And so there's a question in the chat about I think along similar lines of as an emergency medicine physician, I'm sure you constantly see very emotional and probably traumatic cases. I'm curious as to how, or if you have any tips on how to remain an empathetic physician, yet remaining a certain level of detachment as to where you're not constantly carrying all your patient's trauma with you or letting your emotions impact your work.
Yeah. And that is important. I mean, there's a certain amount of compartmentalizing that we have to do, and that's healthy to do. You know, I'll give an example. Pediatric code, who's around 10 years old, pediatric cardiac arrest was called in. And, you know, we worked on him like any pediatric code. We work on them far longer than is reasonable, far longer that makes sense. We know they're not necessarily going to come back, but we know we have to because it's a child. And we just want to know that we could do everything in our power. We want to know that for the patient. We want to know that for ourselves. We want to know that for the family. And when we were working on the patient, not long after, the mother came in, distraught, just knew from walking in and literally falling to the ground repeatedly. I left the code to speak to her because we were really just going through the motions. So the nurses continue like pushing epi at the appropriate intervals. This outcome was not going to change. I spoke to the mother to give her the update, to tell her what she already knew. And I asked her, because when we have critical cases and during the resuscitation, and when it's terminal, we do offer the family, if they want to come in and see the code. And this can sound shocking for people outside of healthcare who haven't been in that situation. However, it's really helpful for a lot of families. It gives them a lot of closure. It's not forced, they're offered. It's helpful for them because a lot of times what they think about is TV, and they think about, oh, just like put paddles on someone and they sit back up and they're fine. But when they see what really happened, and when they encounter death in that way, they understand. They don't have the questions. And typically they want it over, and it gives them some closure when they can say that, and when they can have then moments with their family member who has passed. She did want to come see her son, and we didn't stop until she was there. And she said, stop, it's over. And then she had time with her patient. And it was devastating and tragic. I was also the only doctor in the ER, and there were patients waiting to be seen. So called the code and moved on. Didn't think about it. I kept hearing the cries. Different family members were allowed to come in. But I just went and saw patient by patient by patient. And that's what we have to do many times. And so later when I got home, that's when I thought about it and processed it. And when I was doing, yoga the next day. But in the moment, we get on with the work. And the next shift I have, there's going to be more cases like that. And I get on with the work and I deal with it later.
Yeah, I think, we both have to understand that we have an obligation to our patients in the moment, and that we need to put away and tuck away some parts of ourselves, but also that processing does need to happen later. And I think that that's a part that kind of gets lost in the shuffle of, you swallow it at work and then you just never look at it again, and then that's what leads to burnout.
Right.
I think we've all been feeling quite burned out in the pandemic just generally, because we're in this hyper activated state of like sympathetic response, right? We're constantly thinking fight or flight. And then when you stay sustained in that for such a long period of time, your body just doesn't rest. And things will get harder and harder. And I think in the book, your advice about yoga and meditation and that healthy living will help bring us back down to like our rest and digest mode. But I think also what's so powerful is that you are continuously able to bring yourself back to your mission. That seems to be like your greatest driving force.
Yeah.
And I guess for all the medical students here too, I think figuring that out and really defining that and finding the ways that you come back to those moments is really, really key.
And can I just say one thing to piggyback off of that? That, and also being open and okay with the fact that this path will change and that it winds and that it may take you in a different direction entirely. And that, initially I thought I wanted to be a neurosurgeon. Now listen, we need great neurosurgeons, but then I found out I don't actually like surgery at all. It can just change. I might end up going part-time clinically because there's other work I need to do. And that's okay. This can change. One of my closest friends during medical school, turns out she didn't want to be a doctor at all. And she left. And so and that's okay. I mean, the debt might not have been okay, but her decision was okay. And I just say that to say that we're all going to find, as long as we listen and we have the courage to act on it. Again, there we go. Radical honesty and the courage to act. Then we'll do what's right for us. And what's right for us today, likely, if we're actually being honest and living our path, what's right for us today will be very different than what's right for us 10 years from now. And both decisions were the right decision.
Absolutely. I think that there's so much of that resonates with me, particularly I think I hear the words radical honesty coming around a lot. And I think that in this case, it's very much almost a radical curiosity, right? It's this willingness to like interrogate ourselves over and over again and be like, is this still me? Is this still the path that I'm on? And also to me, that relates back to the idea of like, we all have these biases, and none of us are immune to propaganda. None of us are immune to these signals that come at us from the world. And so we have to, that honesty comes from looking into ourselves and asking the question and then being able to answer it. I think Dom had a question.
I was just going to say there's a question that was submitted that perfectly follows up this discussion that both of you have been commenting on, but it says, thank you again, Dr. Harper, you're a beautiful storyteller. I think we all agree. In your book, many of your patient interactions have common threads to your own life and upbringing. I was wondering what your thoughts are on self-disclosure with patients. Is it ever appropriate to share information about yourself and background to better treat a patient?
So I will say, in this, I'm sure this answer will vary a little bit, maybe a little bit, depending on your specialty. I mean, I'm an ER doctor. I don't have that much. Usually, I don't have much time with patients. Every once in a while I do. It's probably the same for certain surgical specialties as well. I'm sure it's the same for, I don't know, people who are radiologists. You might not have that much time with patients. So because the focus is helping the patient, I think mainly that's what the discussion is is going to be, and that's what it should be. And that may be a little different for people who have long-term relationships with patients or have more time with them in the office. But generally speaking, I think that in medicine, the boundaries we have with patients are appropriate. And then every once in a while, though, I do think I think it's relevant to share some. And this may be kind of funny because, like everyone who's written a memoir, I'm actually a really private person. So it's just how it goes, though. But it can be useful to share some. For example, I recently had a patient and I had some time with him because I had to repair a laceration. So we could talk about his vaccine hesitancy. He wasn't anti-vaccine. He just didn't have all the information. He told me how his pastor kept telling him he needs the vaccine, but he was like, I'm young and healthy and I don't like taking any medications of any kind. So I don't know about this vaccine. So I was repairing his laceration. Great. We have time to talk about it. I asked him if he wanted information about it. I gave him the information. He said he found it helpful. And he said, yeah, but I hear some people, they get sick afterwards and I don't want to feel sick. And so this is an instance where I told him, oh, well, yeah, I had Moderna and I agree with you. Like I'm like you, where generally, knock wood, thank God, I'm healthy. I don't really take medications. And if there's a side effect of something, I get that side effect. And so, yeah, I felt sick too, achy, like a terrible flu. But, that's just the sign that it's working because it's activating your immune system. That's normal. And then I got better and I'm fine. So I said to him that doesn't scare you. Like, I get it. I understand. And I got sicker than my colleagues. So I understand what you're saying. So that was an instance where I shared that information with him specifically to address the concerns we were speaking about. And he found it helpful because he felt like I was a relatable human being. So there are times where I think it's relevant and important to share. I mean, my personal practice is less is more. I don't share as much. I mean, I guess if they buy my book, I guess they'll get more out of me. But I don't bring up that either. Like, that's how private I am. I don't bring up any parts of my other life with patients in the ER.
Kind of on that note, actually, I did find that, obviously this is a memoir where you get to hear so much of your perspective and your patient's stories and little things that have happened to you. But in a lot of ways, I felt like I wanted to know a lot more about you and about your favorite book and the adventures you're interested in. And me and Dom did find out through your Instagram that The Alchemist is your favorite book. Yeah. I just read it, actually.
God, yes.
I was just wondering why it's your favorite book.
Because it gets at following your own path, finding it, and not letting really anything get in your way, and being willing to cross countries just for your own path. And then, of course, finding out that it was within you all along and you had it all along. I mean, just the beauty of it. And then when I read about Paulo Coelho, I'm sorry if I butchered his name, but then when I read about his story in writing this book, okay, do you all know this? So he wrote this book when he was older for an author, kind of like me. I wrote it when I'm ancient, like him, because he was 40, 41, 42, in that range when it came out. And it didn't do well. And his publicist, just because they were his friend, was like, this is not selling. Why don't you take it? See what you can do with it in America. We don't really have a use for it, but we wish you the best. And so still, it took a while that it was out. And then certain people were seen with it, famous people seen holding it. And then all of a sudden it took off. He has subsequently sold millions of copies. And just like in the book, he felt like he was following his own personal journey with the book, and he could not give up on the book, and he could not give up on his writing career. And he knew for himself that there was work he had to do with helping people. They would find their own encouragement through his words. So he couldn't give up. I mean, he was so committed to this. his parents had him institutionalized when he was young. They were like, you're some kind of weird megalomaniac. You're never going to be famous. You need to get a real job, get over this creative thing, like work in a bank, make some money. And he was institutionalized by them a couple times. He wouldn't give up. He kept at it. And now look at him. So I love his story, the story in the book. And so it's just my favorite book that I keep. It is the book I keep on my nightstand.
My version of that book is actually The Little Prince. If you've read that one, I highly recommend. Yeah, I keep that one on my nightstand. I read it every year.
Okay, so we're down to our last kind of 9 minutes. So I think we probably have time for 2, maybe 3 more questions. One question that I think is definitely really interesting, kind of changing topics again, but it says, I trained during an era in which inner city public hospitals were major training sites with little, if any, supervision. Our patients were predominantly people of color, homeless, living with substance or alcohol abuse, or immigrants. At the time, I thought, at least we're here to help, but many patients got very different care than private patients at or at our university hospitals. The implementation of hospitalist care has helped to improve supervision, but can you comment on this structural inequity?
Yeah, I mean, I agree with that. And I had similar, I mean, where I trained, it was similar, except a little different, at least within my institution at that time, where people kind of all got the same care. They all got the same care, but there are differences between poorer hospitals and rich hospitals. And I've worked in systems where, depending on the location where you work, they'll have more than one site, and the rich hospital has all the resources. And the hospital that's in the lower income side, even though this is a major city, so it's not like one is rural and one is urban. No, these are both cities. But the site that's in the poor area, we don't have the specialist. It's harder to get people taken care of. Specialists may not come in to see the patients. Instead, they'll refer them to clinic. Whereas at the rich hospital, they're like, oh, what's the insurance? Okay, yeah, we'll be right there. We'll be right there to see the patient for this fracture. And maybe we'll take them right to the cath lab. Whereas at the poor hospital, it's, they're probably fine. Admit them to observation. We'll set up some outpatient procedure some other time. So that's very real. It's persistent, unfortunately, which brings us back to everything we were speaking about, how we just have to make the changes. And that is part of the reason why I purposely, clinically like to work in lower resource areas, because there's a need, because I want to go where the need is clinically and try and make positive changes there. So again, it happens in the ER in the moment, and then with everything else that we've discussed.
Okay, so I think actually maybe we'll make this our last question. You can take some time to kind of delve into it, but essentially I just want to ask if you have any kind of closing comments. We have a lot of MS1s who are watching this lecture, and I know a lot of them would love to know specifically like any advice that you have for medical school and getting through that, geared towards the first year, but also we have some MS2s, and like every year, maybe even some residents and other attendings that are here and listening. So if you have any general advice to leave us all with, we would love to hear what you have to say.
Just that this is a hard field. It is. It's a hard field. It is not for everyone. And that I think it's prudent to have an open heart, open mind, and open eyes about it. A lot of what we've spoken about doing right by patients and each other and ourselves is hard work, and it's a life's work. You know, and we talked about how there are small changes we can make in the moment, and that's true. But much of what we're doing is trying to make larger changes that are sustainable. And that takes work, like very much, and it can get frustrating, right? But very much like this whole medical career, like everything you had to do to get through high school and college and medical school. And then there's going to be residency. It's a commitment. And in the same way, making positive impacts in healthcare, cultivating a life where that is workable so that you have a life that's fulfilling for you and that makes a positive difference on a larger scale. It takes that same commitment. It takes being open to being vulnerable. It takes being willing to make some mistakes. It takes being willing to make constant adjustments. And all of that is okay. And that is just how this is going to go. And that is good. And as long as we are open and honest and curious, it's also worth it. And I think that for many of us, when we look back, and I never want to like glorify trauma. I know that many of us have been through awful things. So that being said, when we look back on kind of the trajectory of our lives at different points, and I know I can say this for myself, I wouldn't undo anything. I think that I've grown, I've learned. I think it's made me, as we said, more resilient and kind of richer in my spirit. And I think that that's true for many people. So as you go along, I think you'll look back, I hope, and be able to say the same. It was super hard and super challenging, and it was worth it. And it remains to be worth it.
Thank you so much for that. Thank you to everyone who is in attendance today who came to listen to our first lecture. And above all else, thank you so much, Dr. Harper, for being here with us. Everything you've said has been so amazing to hear, extremely meaningful. And I think everyone here will take something away from it. I'm like so grateful. I'm so in awe. I'm like so happy to have you here and that we got to have this conversation and to partake in this first lecture with you, and just many, 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 many thanks.
Thank you. Thank you. It's my pleasure and an honor, and hope to meet some like people in real life one day. It'll be great.
Thank you again so much. I hope everyone has a great first day of medical school. To all of our MS1s that are here. And as we part ways, I hope you remember courage and honesty on our journey.
Congratulations to everyone.
Dr. Harper, do you think we could take a quick little like Zoom screenshot if we smile?
Sure, sure. If it's bad, delete it.
I got you. Okay. 1, 2, 3.
Maybe,
Oh,
sorry,
wait.
maybe we can have the students that are in the Met come up to the front and kind of wave to the camera.
Yeah.
Take the screenshot.
Also, does anybody know what the command is on a Mac? Just take a screenshot.
It's Command-Shift-4.
But that's, you have to like draw the.
Or Command-Shift-3, sorry.
Okay.
Can someone tag me on it or something?
Look at all of them. That's great.
Email it to you.
Okay. Oh yeah, that's great.
Yay.
Oh look.
Oh, that's fantastic.
Oh, that was a good idea.
Yeah, there they go. I love it.
Okay, 1 second, full screen. Okay, are we ready? Okay.
Okay.
1,
1,
2.
2, 3. Wave. Oh, that's great. Thank you, Dr. Harper.
Thank you.
Thank you so much. Bye.